Um, while they're getting my slides ready, I just wanted to also echo what many of my friends and colleagues have said before. For me, it's been about 37 years since I've been back in this building, and while I was not a resident here, I spent about 75% of my rotations from my medical school experience at Columbia, right here at Harlem. So I feel very much at home. Also, I remember quite vividly morning reports, and those were back in the days when you had to do gram stains. I don't know if many of you know how to do it yourselves. We had to do gram stains before morning reports. One of my residents sitting right here, I had to have that done, and that probably impacted me in some ways as I went into infectious diseases and tropical medicine. Having said that, I have to say that I'm actually quite pleased to be able to be here today because Dr. Thompson, whom I knew as a student, and I know a lot better now because of other interactions, certainly for me and for people like myself has always been a trailblazer. So now I'm going to talk about a little bit different things. I'm going to talk about sex. You see, we have talked about the hypertension, the diabetes, the stroke, the heart disease, the what have you, and the what not. And plus, I just have a little bit of an issue with the word elderly. As I have gotten much older, I just think it's more mature. So, right? Okay, so you're elderly to me if you're about 97. I give you that. So now I am a member of CDC campaign. I pretty much have traveled all over the world doing teaching and what have you relative to HIV, and some of it with tropical medicine. But for the CDC campaign, I'm one of the people that they would like to address the issue that prevention is care. And I'm going to posit to you that many of the patients that you are seeing that we consider more mature are at risk for HIV, but do you ask them about it? Absolutely not. What you do is you take care of the hypertension, the diabetes, and everything else, and you forget that they are having sex. So we're going to talk about that a little bit. And plus, the issue about that is they're engaging in risky behaviors for which they don't think it's a risk, and even the providers are complicit, because how many of your patients, when you're doing a complete physical, which you actually have to take the clothes off to do, right? Something I learned here. Because people are now examining people through their clothes, they're listening to the lungs and things like that. You got to take the clothes off. Anyway, so remember, this is important. I live in Washington, D.C., and I've been in Washington, D.C. for the last 37 years since I left Columbia to do my residency. I've done a fellowship, I've done research, and I'm back to Howard, including a stint in the Senate. And at the end of the day, prevention makes a difference. So here are the statistics. By 2014, about 73% of the people that were diagnosed with HIV were in care. Only 73%. It really should be greater than 95%. Of those that were in care, only 58% were virally suppressed, meaning that if you looked at what their immunological system was doing, you could still measure viral activation, which is not a good thing. As most of you know or should know, HIV is primarily an inflammatory process. So if you're HIV infected, your hypertension is going to be worse, your diabetes is going to be worse. Everything that you have is going to be worse because it's an inflammatory process. And even being on antiretroviral therapy doesn't mean that that immune activation that goes on with HIV goes away entirely. It's just mitigated. So that's an important concept to understand. So the initiation of early therapy is important. It's important for a number of reasons. If you initiate therapy early, you are lowering the viral load, that means that your risk of transmission, if that's the only thing you do, to someone else is mitigated. So we'll talk a little bit about that as I move along. Now, retaining patients in care. I have been involved with HIV since the 1980s. When I was a fellow at NIH, Bob Gallo was just down the lab, down the hall from myself. HIV exploded and no one knew what it was, and pretty much I've been dealing with this in the dark ages. Now in the lighter ages, you know, we have medication. It's like a Chinese menu. You can take one from column A, two from column B, and now you can just take one. Makes a difference. So there's a lot that has changed, but a lot has still not. Stigma that's associated with HIV still has remained almost undaunted, although you don't see it manifested in the same way. So retaining patients in care has been a major issue for most of us that practice medicine, and that now is also the primary care providers in the community. So discussions about sexual behaviors is something that every primary care provider, be it the physician, be it the nurse practitioner, be it the PA, must have with each patient that they see. And you shouldn't assume just because they're more mature that things are not happening, because I can assure you they are. So now here are some other statistics. When they looked at screening amongst older adults, what was found was that most of us are getting older. Well, some of us are getting older, and so we are constituting a significant percent of the U.S. population. Matter of fact, it's predicted that by 2030, about 20% of the U.S. population is going to be over the age of 50. By 2015, those that were HIV infected were 50 years and older, those living with HIV. Certainly in the practice that I have, that's clearly somewhat limited now, because I supervise. We have patients that are 85, 80. I have a lady that's been my patient for the last 22 years. She's 77 years old. So our patients are aging with this disease, and I'll give you a real sad anecdote of missed opportunities. That missed opportunities, I will just name Mr. Jones. Mr. Jones was a deacon in the church. He's been going to his primary care provider for a number of years, had a little arthritis, a little hypertension, and whatever, and had been followed for maybe 5 or 6 years for some unusual symptoms that no one seemed to be able to put their hand on. Finally, he was referred to me. I really can't remember why he was referred to me. Of course, the first thing that I'm talking about is, "Hi, Mr. Jones, I'm Dr. Maxwell. How are you doing?" And some other niceties, and then I go, "You know, Mr. Jones, you're having sex? Who you having sex with? All right. Is everything covered up?" You know, the concept for most of our more mature individuals of protection is something that younger people do. And so, again, a missed opportunity. The long and the short of it, Mr. Jones, name is changed, of course, was HIV infected, had been HIV infected for about 5 years. Viral load was about 250,000. His CD4 cell count was 40. This man had been compliant with every single medical visit that he had. He had kept them. Missed opportunity, all right? So the low perception or the low risk perception of HIV, even amongst primary care providers and the patients themselves, is a concern to us. And when you look at that last thing there, only 52% of tests were suggested by a primary care provider. So now, what about the new diagnosis of HIV infection in those that are over the age of 50? 44% of all new HIV diagnoses for adults, right, as far as the CDC stats, were for adults age 50 to 54. That should be concerning to all of us. And that indeed could be considered, one of the at-risk populations, because the perception of risk is almost non-existent, the way that it is structured in the literature, which mostly focuses on younger individuals. Race and ethnicity, again, there you go, African Americans, by far the most impacted, most affected. Transmission mode, men that have sex with men, even covertly. And so you have to be non-judgmental, and you just have to ask. That way you can provide the services that are needed. Now, one of the most concerning things is the disproportionate impact of this infection on women that are of color, particularly African American women. So nationally, the statistics for women that are of color, African Americans are about 19% of the population of women, yet they account for about 60% of the women that are infected with HIV. All of these women are not what you would traditionally consider at risk. They've never used drugs. They have never engaged in the sex industry. You have to say sex industry now, right? They've never done anything like that. Yet they were at risk and were unaware that they were at risk. So we need to do something about that. When we look at those individuals that are actually living with HIV, that are 50 years or older, you can see, again, race and ethnicity, and you can see transmission rate. I don't think this is moving. Awareness. Now, this study looked at awareness, and most assume it's something that impacts young people or younger people. And, in many instances, I have pastors asking me to come to their churches, and I make sure that I say, Pastor, you want me to talk like I do because this is church? And they would say, go ahead and preach. I say, okay, I'm just a doctor. I am not a religious expert by any way or any means, so I just let people know the questions you should ask, what you should do if you feel that you've been at risk. So now this is of concern because sexual transmission is actually the leading mode of transmission for most mature adults. But what also we are finding is that a lot of our patients that are older are actually engaging in using drugs. Many are smoking marijuana, and you'd be surprised. My friend said that if you smoke a joint now and then, your glaucoma or your diabetes or your everything gets better. The experts are here, you can tell me, right? For my part, I have been blessed with asthma, so I can't smoke anything, never have. So I can't say that I have had the experience. But if you talk to your patients, you will be surprised at what they will share with you. So you really do have to take a minute. You can't assume, and you have to make them feel comfortable that you're not going to judge. Again, the impact of the healthcare practitioner, whomever he or she might be, is extremely important. So now, this is a study that looked at sexual risk-taking behaviors in adults. They're very limited studies, right? There's lots of studies in younger people, but very limited in older adults. And here is what was found. There was a low prevalence of condom use among older adults, even if they were not in a long-term relationship with one partner. I should digress, because for many in our communities, monogamy means one person at a time. We understand that monogamy means one person for a lifetime. You have to speak the language, so I'm being irreverent, Dr. Thompson, please forgive me, but you really have to talk to your patients. Also, you see that substance abuse is increasing. It could be closeted alcohol use, or it could be other substances of abuse, and older adults are likely to be diagnosed later with other HIV medical-related disorders, like the patient that was referred to me. That was a late diagnosis, that was a missed opportunity, something that should never have happened. And so again, clinician education, it's important. So my last two slides, this is just the challenge of managing HIV and other disorders in adults. And this study was actually done here in New York City, where they looked at about 1,000 people. The breakdown is shown there. About 50% of the respondents were African American. 90% of them had at least one comorbidity, and they're listed there. And look at the current use of illicit drugs, right, in this population, which you would never think would be something that would happen. It included marijuana, it included crack cocaine, it included heroin. So they're not using it in such quantities for you to see the outward manifestations, but they might be engaging in this anyway. My last slide, again, is just to remember that prevention is care. You know, patients come to you, and here is another anecdote. When you talk to patients like I do, they say, well, you know, I went to the doctor, he takes a lot of blood. He checked me for everything. Most patients assume you are evaluating them for things including HIV. I posit that that's not the case, and that evaluation for things like HIV and other STIs should be a common part of the annual physical, if that's something that you do, or any evaluation that you do, just as much as the cholesterol, the blood glucose, and what have you. So with that, I will stop, and I'll take your questions after. Thank you.